Hello and welcome to my YouTube channel. My name is Dr. Syed Kazmi. I'm a pediatrician and today I'm going to talk about chest pain in pediatric practice. Now, as I usually say before start of my lectures, if you are new to my channel and you haven't subscribed yet, please do subscribe and press the bell notification icon so whenever I upload a new video, you are always on board with me. And if you like my videos, please do give me a thumbs up and share my videos with your friends so that knowledge is spread. So coming back to today's topic, and that is chest pain in pediatric practice, a very common complaint which all of us see in almost everyday pediatric practical practice. Now, it mostly occurs in adolescents. Most of the cases who would come to you in your clinic would be in the age bracket between 10 to 17 years. Though, to some extent, it can also occur in younger children like between 5 and 10 years of age. But by and large, majority of those who will have this problem would fall in the age bracket between 10 to 17 years. This is considered to be a cause of great parental as well as patient anxiety. Why? Because most of these guys who've got chest pain, they think that something is wrong with their heart. That's why sometimes when they are describing their pain, instead of saying they've got chest pain, they say their heart hurts. It's simply because they've been told that the most important organ in their chest is heart, and that's why everybody is so much worried when they have got pain in their chest. Now, it's also important to know that unlike adult medicine, in pediatric practice, most of these cases of chest pain are non-cardiac in origin. In other words, I would put it down that around 98 to 99% of the cases of chest pain are non-cardiac in origin. Only 1 to 2% of these chest pain cases would be having something wrong with their heart. But again, by and large, majority, when again we say majority, it's not 75-80%, we are talking about 98 to 99% of these cases who haven't got anything wrong with their heart. Now, how do they describe their pain? Most of the time, majority of them, they would say that they have got stabbing pain. They would describe it as stabbing. And it's not that they say that this pain started after doing some exertion or is aggravated by doing exertion. They say like, well, they were watching TV or playing their video games or whatever, and all of a sudden they felt a sharp stabbing pain. Majority of them, they would say that it's there in the central part of the chest, but some of them would say it's all either on the left side or on the right side or generalized spread over all of the chest. And again, as most of them, they would say they were either writing or watching TV, and all of a sudden it started. Or some of them, they might say that it's been occurring again and again, so there is a recurrent nature to this pain. Or some may say that this pain has been persisting there for days, even weeks. So it could be acute, sometimes it could be chronic as well. So it can present in a wide variety of ways. Now, moving on, talking about the causes of chest pain. Again, I told you that 98 to 99% are non-cardiac in origin, while 1 to 2% would be cardiac in origin. Now, as far as the non-cardiac causes of chest pain are concerned, again, a big chunk of these non-cardiac causes are caused by musculoskeletal problems. When we say musculoskeletal problems, it might be caused because of repetitive strain to the chest wall musculature, or it might be caused by trauma, like for example adolescents who are playing contact sports like rugby, football. They might have suffered an injury to the chest either because they've been elbowed or kicked or hit by the ball in the chest. In most of the cases they might remember, but in some cases they might not even remember what had happened to them. So musculoskeletal causes are by and large one of the most common causes of non-cardiac causes of chest pain in the pediatric age group. Another subset of musculoskeletal problem is what we call as costochondritis. Costochondritis simply means that there is an inflammation of the costal cartilages. Now these are the cartilages in the center of the chest. You've got this the central chest bone, which is known as sternum, and from the side the ribs come. So the ribs are attached to the sternum with the help of a thick cartilage, and this cartilage can get inflamed by repetitive strain. Sometimes it gets inflamed even by febrile illnesses, but most of the time it's because of repetitive strain, because they are stretching their costal cartilages too much, either doing exercise or playing sports. So you know, kids are always very active, so there is always a chance that there would be an overexertion of these costal cartilages, and that can lead to sort of an inflammation in these cartilages, which we call as costochondritis. Now, it's very important that whenever somebody complains of chest pain, and again we said that most of the cases are non-cardiac in origin, and again big chunk of these non-cardiac are musculoskeletal in origin, including costochondritis. Remember, one of the important techniques when you are taking a history and you are doing your physical examination, try to palpate the chest. Why? Because if you can reproduce the pain by palpating the chest, so you palpate the different parts of the chest, especially the costal cartilages. So if the pain is reproducible by pushing down on the costal cartilages or the chest wall, that is always musculoskeletal in nature. And especially if you press on the costal cartilages and it hurts, then it is costochondritis. Or you can simply ask them to stretch. So if they stretch, like their arms outwards, that would put sort of pressure on the costal cartilages, and that again reproduces the pain. That is another indication that this is costochondritis. So the musculoskeletal causes could be number 1, trauma, as I already explained. Number 2, it could be costochondritis, or sometimes there might be a rare condition called the slipping rib syndrome. Now, what happens in slipping rib syndrome is that the lower ribs, the 9-10 especially, so some of them, they might not be attached to the costal cartilages. So there is a lot of movement, free movement, and when there is free movement, the intercostal muscles which are attached between the adjacent ribs, that gets stretched a lot. Why? Because these floating ribs, free ribs, are not attached to the costal cartilages. So that leads to a bit of stretching of these muscles, and that causes pain in the lower part of the rib cage. So if you palpate and if you feel like a excessively moving rib, that might be the slipping rib syndrome, which also causes pain in the lower chest. And again, that is usually a recurrent pain. Whenever they're doing sports or something, they will get this pain on and off again and again. Then after musculoskeletal causes, the other common group of non-cardiac causes which can give chest pain is gastroesophageal reflux. Now, gastroesophageal reflux basically is the reflux of the stomach contents back into the esophagus. So because of a lax lower esophageal sphincter, and sometimes because of dietary reason, we know adolescents they usually have got a crappy diet. They're mostly into fast foods and oily foods and other things. So that can sometimes cause increase in the secretion of the stomach HCl, and these contents can regurgitate back up, and when they regurgitate back up into the esophagus, they can cause an acid reflux spasm or burn. So they would complain of a central chest pain which might be burning in nature. It might be going up, radiating up, or it might be sometimes radiating back as well. So gastroesophageal reflux after musculoskeletal causes is one of the most common non-cardiac causes of chest pain in children. And it might be worthwhile that if painkillers are not working, you can try some acid blocking drugs like omeprazole, and you might see a pleasant surprise in terms of the response given by these kids, that the pain has gone away. Then the third non-cardiac cause of chest pain could be causes in the lungs or the airways. And there are different types of airways issues. Number one, asthma, which is quite common in the pediatric age group these days. An asthma attack can cause chest pain as well, because in asthma attack there is tachypnea, there is increased work of breathing. These intercostal muscles are not very strong, so an increased work of breathing can quickly exhaust these muscles and they might feel pain in their chest cavity. So asthma can cause chest pain. Other cause of chest pain is that because of some issues like connective tissue disorder or something, if the airway has got a leak and there is escape of air either into the pleural cavity or into the mediastinum, that might also lead to pain on either one side of the chest or in the center of the chest. So we would call these conditions as pneumothorax and pneumomediastinum. Now, usually these types of pain are associated with some form of difficulty in breathing. So when you are examining them after palpating their chest, you would definitely use your stethoscope to listen to the breath sounds and heart sounds. So if the breath sounds are decreased on one side and the percussion notes are hyper-resonant, then you might think that there might be collection of air on that side in the pleural cavity. That means pneumothorax. Pneumomediastinum is a bit more tricky because it's not easy to diagnose unless and until you do a chest x-ray, and in chest x-ray you might see a silhouette of air in the mediastinum, especially around the heart or around the central structures in the mediastinum. So asthma, pneumothorax and pneumomediastinum are some of the causes, lung-related causes that can cause chest pain. There might be some other causes as well, like pneumonia. A chest infection can give you unilateral chest pain, but that obviously is quite obvious because the child has got high fever, he is coughing, might be bringing up sputum, and they've got unilateral chest pain. So that's more obvious, it's easy to diagnose. Or some adolescents, especially obese females, if they are using oral contraceptives, they might suffer from pulmonary embolism, especially if they've got like some problems with their clotting factors as well. So they might complain of chest pain, but again, with that chest pain, they would be having tachypnea. They might be having some other pointers in the history that might point towards pulmonary embolism, and it's not that common in the pediatric age group. And then another important thing which we see a lot in our practice is anxiety. So adolescents who have got some form of anxiety, it might be anxiety associated with other issues like attention deficit hyperactivity disease or autistic spectrum disorders, or they might have got some social issues which has led to anxiety. They might feel chest pain again and again, and that is very weird type of chest pain because they would usually be presenting, there is a long history of presenting again and again with chest pain. In many cases, majority of them have undergone different investigations like baseline investigation, repeated ECGs, repeated x-rays. Some of them might even have the echoes done and everything has come out to be normal. They have even been worked up for heart attacks and things like that, but everything has been normal, but they present again and again, and usually there is an element of anxiety. So again, sudden onset of stabbing pain, and usually it moves around. So sometimes they say pain is here, next time they say pain is on the right side, on the left side. They feel numbness in the arm, it's going to the jaw, they have got headaches, and a myriad of different symptomatology that goes more in favor of anxiety. Then coming down to the cardiac causes, which are quite rare, 1 to 2% of the chest pain would be related with the heart. Now, the important heart problems which can cause chest pain are the structural heart problems like hypertrophic obstructive cardiomyopathy, in which there is asymmetric thickening of the interventricular septum, which leads to left ventricular outflow obstruction, and that obstruction increases when they are doing sports. So usually the cardiac causes usually present with chest pain while doing sports, like doing strenuous activity, whether that is sports, whether that is running, whether that is jogging, and usually they've got difficulty in breathing associated with that chest pain, and majority of them they even pass out, because with that structural heart defects there is reduction in the cardiac output, which means less oxygenated blood going to the brain, and they usually pass out. So if somebody has got a history of chest pain most of the time while playing sports, or there is a history of their family members having heart problem at a very early age, or somebody dying because of heart problem at a young age, then you should be thinking of structural heart defect. So hypertrophic obstructive cardiomyopathy, aortic stenosis, again they all present. In both these cases there would be reduction in the cardiac output, especially when they are doing exertion. Some of the other conditions like inflammation of the myocardium, myocarditis, or the pericardium, pericarditis. Now these are viral conditions, and usually they are associated with fever, or they usually occur after a febrile illness. So they usually had a very bad like febrile illness, and as they are recovering they might develop chest pain. And obviously myocarditis is a danger, so there will be tachycardia with that. There might be associated features of heart failure with that. So usually these kids are quite unwell, and they have to they usually they come in, they have to be admitted for workup and everything. Tachyarrhythmias, kids who have got some problems like supraventricular tachycardias or Wolff-Parkinson-White syndrome, things like that, they can have episodic tachyarrhythmias which might lead to chest pain. But most of these cases have already been diagnosed, unless and until they have been completely out of the radar screen and somebody presents with their very first attack. Another important thing which is quite rare is the anomalous origin of left coronary artery from pulmonary artery. We call it AlKappa. That means anomalous left coronary artery arising from pulmonary artery. So this is an abnormal origin of the left coronary artery coming out of the pulmonary artery. And pulmonary artery contains deoxygenated blood. So sometimes if there is spasm of this artery, that would further lead to reduction of the blood going into the heart, and they can suffer a heart attack like symptoms, chest pain. So AlKappa is one thing. Again, it will be picked up on angiograms, maybe sometimes even on echocardiogram, but that is quite a rare condition. So these are some of the common non-cardiac and cardiac reasons of chest pain. Now, how do we do the workup? Now, we only do workup if needed. If the history is very obvious because you think it's a musculoskeletal reason. Why? Because you can reproduce the pain, or there are obvious features of costochondritis, then you don't need to do any workup. All they need is reassurance. All they need is appropriate analgesia, pain control. So you can give them paracetamol, you can give them non-steroidal anti-inflammatory drugs, and they need to take rest from the sports and things. Though the recovery is not that quick, it might take days, it might take weeks. We only do workup if we are suspecting cardiac reasons. And what are those workup modalities that we do? The first important thing is ECG. So ECG can identify tachyarrhythmias. ECG can identify if there is septal hypertrophy. ECG can identify if there is left ventricular or right ventricular hypertrophy or axis deviation. So these are non-specific things that you can pick up on ECG, which can further give you a clue whether there is a cardiac pathology present or not. In most of the cases, it cannot pinpoint the diagnosis, but it can give you an idea if there is anything wrong with the heart or not. That can be followed up with a chest X-ray. Again, these two modalities are something that you can do in your office, that can you do in the emergency departments. A chest X-ray can show you some of the features of structural heart defect. Like for example, if somebody has got a cardiomegaly, that can be picked up. If there is pneumothorax, that can be picked up. If there is pneumomediastinum, that might be picked up. And the actual diagnosis comes through echocardiogram. So if you are thinking that this kid has got hypertrophic obstructive cardiomyopathy or aortic stenosis or anything, then they must be referred for an echocardiogram, which would be more specific for picking up the different types of heart lesions. Now coming down to the treatment again, it depends on the underlying condition. So if they've got musculoskeletal reason, then they need to take rest. They need to take painkillers, and it would take some time before the thing completely, gets cured. You also need to give them reassurance, because most of the time the problem is that they are thinking that something is wrong with the heart, though in fact it is not. So reassurance is very, very important, telling them through statistics that it's, very rare for kids to have heart problems, and what are the features of the chest pain if there is an underlying cardiac pathology. So that way you have to give them some reassurance, and if there is a cardiac reason, then you have to refer them to the cardiac specialty, because they would need some specific form of drugs and some specific form of intervention. So my friends, this was a short video on causes of chest pain, which is a very common presentation to the emergency departments as well as pediatric offices. I hope this video will help you in understanding the different causes and in further refining your approach and diagnostic workup for these presentations. If you still have got a question, please put it down in the comment section below and I will answer as soon as possible. So thank you very much for watching this video. I'm signing off. Have a very good day. Bye-bye.